In this video, we'll talk about Vibrio Cholerae. So Vibrios are curved gram-negative bacilli. So they are curved with a single polar flagellum. So they are actively motile. Vibrio is because of its characteristic vibratory motility. Okay. And next, habitat. Vibrios are ubiquitous, found worldwide. So being salt-loving, they are halophilic. So the natural habitat is marine environments. So most important, V. cholerae, they cause a devastating acute diarrheal disease cholera and has been responsible for 7 global pandemics worldwide. So based on salt requirement, they're classified into non-halophilic Vibrios and halophilic Vibrios. Non-halophilic grow without salt. Example, V. cholerae, and halophilic grow at a higher salt concentration. So 1% and 10%. So examples are PAV, Parahemolyticus, Alginolyticus, and Vulnificus. Okay. Next, moving on to the classification of Vibrio by the Gardner and Venkatraman classification, you can classify it into Vibrio Cholerae and other Vibrio species. So halophilic, non-halophilic. So Vibrio Cholerae based on serogroups O1 and O139 and non-O1 or non-139, so they are non-agglutinable by the O1 antisera. So then O1, again you can divide into classical and L-tor. Each classical and L-tor you can further divide into serotypes Ogawa, Inaba and Hikojima. So classical is responsible for first 6 pandemics and L-tor is for the 7th pandemic. So O1 serogroup is agglutinated by O1 antisera, responsible for all pandemics and most of the epidemics. And non-agglutinable ones are not agglutinated by O1 antiserum, so they are non-cholera vibrios, initially thought to be non-pathogenic. Next, O139, it has caused several epidemics and outbreaks in coastal India and Bangladesh. Okay, so O1, non-O1, O139 serogroups are causing occasional sporadic outbreaks of diarrhea and extraintestinal manifestations, but never epidemics. Okay, so moving on to the differences between classical and L-tor versions. So remember this thing, classical is only positive for 2 things. So PB, okay, poly B Mukherjee 4. Poly B Mukherjee 4. Okay, so polymyxin B testing and Mukherjee phase 4 testing. Next, all L-tor is positive. So CAMP, chick erythrocyte test, Mukherjee phase 5 test, Vokes Proskauer test. Okay, 5 and V is like 5, right? So again, blood agar hemolysis. Next, pathogenesis of cholera, it is toxin mediated. So both O1 and O139 are capable of producing cholera toxin. So mode of transmission is by ingestion of contaminated water. Infective dose is acid labile 10 power 8 bacilli. So Vibrio vibrate 8 10 power bacilli. Next, factors promoting transmission. So where gastric acidity is reduced. So hypochlorhydria, use of antacids, etc. So how does it cross the mucus layer? So it secretes mucinase and also because of its motility. And also adhesion and colonization, once it gets through the mucosal barrier, it adheres to the epithelial cells. So it is facilitated by a fimbria called toxin regulated pilus, so TCP. So cholera toxin, TC, reverse it, CT, so reverse it TC, you get TCP, pilus. Cholera toxin resembles the heat level toxin of E. coli in its structure. It has A and B fragments. So fragment B is the binding fragment, binds to gangliocyte receptors, GM1 gangliocyte receptors, and A is the active fragment. It causes ADP ribosylation of GS protein, causes accumulation of cyclic AMP, and this again further results in accumulation of sodium chloride in the intestinal lumen and accumulation of water, so isotonic fluid, loss of fluid and electrolytes, and shock due to prolonged dehydration, and acidosis due to loss of bicarbonate. So pathogenesis, the gene for cholera toxin, it is phage coded. It is encoded by CTX. It is integrated as a prophage into the chromosome. It also codes for TCP. Okay. Next, other virulence factors. So remember cholera. So cloes, lips occlude. So LPS, bacterial endotoxin, and occlude. So occludens toxin. Next, clinical manifestations include asymptomatic infection, mild diarrhea or cholera, asymptomatic, mild, and explosive life-threatening diarrhea. So you can also see rice water stools which mimic arsenic poisoning. Next, so what is the progression of symptoms according to fluid loss? So less than 5% there is increased thirst. At 5 to 10% you are losing water rate, so your BP decreases. According to Murray's law, your heart rate increases, so tachycardia, and also there is weakness. At greater than 10% there is oliguria, sunken eyes, sunken fontanelles, etc. Next, moving on to the epidemiology and the history of pandemics. So the first 6 pandemics were because of classical Vibrio. They originated from Bengal. 7th one was outside India, and it is because of L-tor. So it was first isolated from Chennai, okay, the O139 strain. And the Bengal strain, it differs in having a distinct LPS and capsule, okay. And moving on to the epidemiology, West Bengal is no longer the homeland. All states are affected. Both morbidity and mortality have greatly reduced. So reservoirs, humans are the only reservoirs. Carriers, asymptomatic carriers play an important role in transmitting cholera over long distances. Altor has more carrier rate. So cholera season, high temperatures, heavy rainfall and flooding especially. And then factors determining the severity of disease. So immune deficient people, and also blood group O has a greater risk. So cholera, O greater risk. AB has the least risk. And persistence, so in epidemics it is maintained by carriers and subclinical cases, and inter-epidemic period it is maintained in seawater, halophilic, right? Other ones. So resistance, it is acid labile but stable to alkali, heat labile but stable to refrigeration. It is easily killed by sunshine and detergents. So lab diagnosis, you can take the stool specimen or the rectal swab. So VR medium or Carrie Blair medium is the transport media. So they are gram negative rods, okay, gram negative rods and coma shaped, and on wet mount you can see fish in stream like appearance, okay, darting motility on hanging top experiment. Next, culture, you can use alkaline peptone water as the enrichment broth. Selective media, so what is there? Monsour's GTTT agar and TCBS agar, thiosulfate citrate bile salt sucrose agar, which is producing yellow colonies, and it is best selective medium for Vibrio. Next, culture smear and motility testing, you can see darting motility and short curved gram negative bacilli. And also identification, basically remember coins. So catalase positive, oxidase positive, indole positive, and for nitrate reduction positive, and sucrose lysis and string test positive. So coins positive and IQ plus minus, okay, just remember coins positive, that is enough. String test is basically stool plus sodium deoxycholate produces strings, okay. Next, moving on to the lab diagnosis, biotyping is to differentiate classical and Elter, serogrouping to differentiate O1 and O139, serotyping, Ogawa, Inaba and Hikojima serotypes. Next, antigen detection by cholera dipstick assay, molecular method by PCR, antimicrobial susceptibility testing. Treatment is by fluid replacement, which is the most important measure. In mild to moderate fluid loss, you can give ORS. In severe cases, IV fluid replacement with Ringer's lactate. Next, treatment, antibiotics play a minor role as a pathogenesis toxin mediated. Use only antibiotics in severely dehydrated patients as per WHO guidelines. Drug of choice is macrolides, cholera macrolides such as azithromycin. Next, prevention, safe water, sanitary disposal of fishes, proper food sanitation, and health education, etc. Next, vaccines are no longer in use as they provide little protection and cause adverse effects. So you have the killed whole cell vaccine. It is composed of killed whole cells of Vibrio Cholerae, the O1 and O139. So 2 doses are given with 2 weeks gap. Next, whole cell recombinant B subunit vaccine, binding subunit vaccine. So 2 doses are given orally, 1 week gap. And again, oral live attenuated vaccines are also given. And non-O1, O139 V. cholerae, they biochemically resemble V. cholerae but do not agglutinate with O1 or O139 antisera. So gastroenteritis, they cause that because upon seafood consumption or raw oysters, etc., stool is watery, there are abdominal cramps. Treatment is same as that of cholera. And finally, extraintestinal manifestations are seen, such as otitis media, wound infection, occupation because of occupational or recreational exposure to seawater. It is sensitive to tetracyclines.